And here at VHHA and the project lead for our sepsis program. I'd like to say good morning and happy holidays to everybody. This is the sixth webinar that we presented for our hospitals as part of the Sepsis Special Innovation Project. As you will see, Kathleen, can you go back one slide?
Sure.
There you go, thanks. This is your sepsis support team, of course, and Lisa Mark, picture in the middle. She is our project lead for the nursing homes, the rest of the team there. Today, we round the year out with another very informative webinar, again with our very special guest, our sepsis content expert, Kathleen Vollman, and she is going to address bundle compliance issues and concerns and our patient outcomes. So, at this time, I will turn the presentation over to Kathleen. Thank you, Kathleen.
Thank you so much, Joyce, and thanks, guys, for carving some time out. Data is an important component, and it is tier 4 in the process that we talked about, discussing key milestones of this, measuring success and continuous improvement. And I'm going to just review, depending on the amount of time, the core measure changes that came to effect or were addressed in July of 2017. If you remember, here is the tier process for program implementation, and we are now at the top of the pyramid, and that is measuring success and doing continuous quality improvement with that data. And so what are the milestones in our checklist for this is defining what outcome and process data elements that are going to be collected, and a lot of that's been defined for us through the core measure abstraction. Develop and implement a data collection process, and this I'm going to spend a bit of time on because I think it's important to understand the data that we're getting and how to use it and what type of data, whether it is concurrent, prospective, or retrospective, and which data is superior in terms of our ability to make change happen in revising and updating our goals and action plans and doing the continuous improvement that is repetitively needed. Just want to remind everybody, I'm sure I don't need to remind because this is probably set in stone for you in terms of your knowledge of the SEP1 measures, the first 3 hours, and remember time of presentation defined as earliest of chart notation when all elements are present. And then understanding that time 0 can come from anything, as we talked about before, and that's why there is a benefit to embedding screening into the nurse's shift assessment, because at a minimum, at least every 8 or 12 hours, the nurse is asking all 3 of those questions. Presence of surge criteria, known or suspected infection, and do I have a new acute organ? So one, it makes it easier for your coders and chart abstractors, but the other is the data has really shown that embedding this type of screening increases early recognition. And then the second component of the time frame of the 6 hours of presentation includes the vasopressors and what to do with persistent hypotension and reassessment of the process. And so I'm just making sure that we're all on the same page before we start talking about data. So what kind of data collection? I would really ask you to think about creating patient logs if you have not done this already, because there is no question real-time data collection is optimal. It is a pain. That's the reality. But if you're really going to understand what's going on and know your data and be able to respond to it in a time frame that's going to change behavior, real-time data collection is critical. So a lot of times people have initiated patient logs in the emergency room, also in the ICU, as a way for a sepsis coordinator or an individual responsible for data can go on a daily basis and identify patients that have been put in the log and follow them. and see where they're at in the bundles in the process and collect data that way. So in terms of what kind of data, yes, we do want to look at mortality, both ICU and hospital, length of stay, cost per case, if you're able to extract that data, because it makes an argument as to what sepsis is costing your organization in order for you to attain more resources for your program. So that's helpful. And then the process is the core measure and looking at both the 3 and 6 hour bundle measurement components. This slide actually was, or the information was obtained from the Surviving Sepsis Campaign website through the work that they have done nationally, and I will also share with you, this is a process that I follow as well. As you can see, there is only one use for retrospective data. And so when we look at that, that literally is recommended for advanced improvement teams and those that already have a demonstrated success with process measures. Where we want to do concurrent, data abstracted in real time or within 24 hours, that allows an individual or a coordinator to take that information back to the clinicians to understand why decisions were made, why this patient went to the floor instead of the ICU based on their clinical picture, or they did go to the floor and they deteriorated, and that ED would have never known if that feedback didn't come back. Because what we've identified over time is that if it's 4-week, 6-week data, the likelihood that you're going to change individual behavior and practice is really tough. If you collect a prospective, like on a sepsis checklist, where you're actually using it as not only documentation of data collection, but you're also using it as a real working tool of what we have done so far in the bundles once they've been initiated. It can help you serve as a prompt for the next phase of the bundle. It can also serve as a strong communication tool linking you to the next phase of care, whether they go to the floor or the ICU, of what's next. And so it gives you an idea, needless to say, retrospective, and it's a lot of what we do, but it is the most challenging data to be able to use effectively for process improvement. So some of the common challenges is how do we use this data? Where do we take the feedback? Is there accountability for it? And so part of this also comes with the base of the pyramid and understanding why you need a sepsis committee or a sepsis team that meets monthly, multidisciplinary, that has your nurse and doc champions, that have lab and radiology and pharmacy, so you can solve some of the systems issues that you run across as you dive into your data, and that accountable executive that understands and can help push through those barriers. And the key is timely feedback of data to this group so that they can do something about that data. And really, the sepsis data needs to be permeated through the entire institution. Sepsis team meetings, quality meetings, patient safety meetings, unit-based meetings, medical staff and department meetings, and even at board meetings, so that that sepsis and the data around it are on everybody's tongue to make it happen. And providing specificity in that data with the bundle elements compared to patient outcomes and to the goals that we have set for the program. And sometimes also individual case feedback based on reviews that are done either by the quality department or by the sepsis team itself. And there is an example here of a tool for reporting individual feedback to providers. So if you don't have time to have an individual conversation, this can come from abstracted data, it can come from real-time data, but the information is sent back to that individual provider so that they can look at the feedback and make changes in their individual practice. So when you have your data, it's really important to break that data down so it becomes meaningful to drive process improvement. So what does that breakdown kind of look like? So these are some examples. Really understanding your volume of simple sepsis, severe sepsis, and septic shock, and breaking that caseload down so you know what you're dealing with. And also then begin to stratify that data by present on admission, not present on admission. Is it medical patients versus surgical patients? What was the discharge disposition? And all of that can be broken up by the disease severity. So was it simple sepsis, severe sepsis, or septic shock? Therefore, you can literally get a very honed in picture of where your issues are so that you can do targeted improvement, which has a greater chance of having the impact that you'd like to see. Another example of how you would do that is looking at your mortality date or data rate, separating it. So this is an example, separating it by present on admission versus non-present on admission, and looking at the mortality rate based on the severity. So, for example, the green here is listed as simple sepsis. So you can see that's been pretty stable. You can see that they've had a very significant drop from about 15% to close to 2 or 3% in severe sepsis, where the process, where their mortality rate has not changed much, is in septic shock. And so this would be a group where I guess I would, and then I'd break it down based on present on admission or non-present on admission to determine how I can impact my septic shock mortality rate, because that's where I would get the biggest bang for the buck in my process improvement. Another look at outcome data would be on length of stay, and this could be done by severity. So you could pick a severity, and this is just building a database, and we have very creative individuals within our organizations to help us do this. But picking the severity and then getting average length of stay, and then what is called a geometric mean length of stay, which is what Medicare uses, because the geometric, and you'll see the geometric mean length of stay is lower than the average length of stay. Most hospitals, most of us, use the average length of stay. But what is nice about the geometric mean length of stay is the fact that it manages to muffle or reduce the impact of both short and long lengths of stay. So those outliers, to give you more of a base of what you're really experiencing in your organization. It's important to get process metrics as a part of this. Overall bundle compliance, for example, this organization showed close to a 60% overall bundle compliance, and this is examples of each of the components of the bundle. So one can identify where the potential improvements are needed as a part of this journey, and I just wanted to give that example. So now, taking it from the global, I'd like to take it to the more specific and take a look at some of your data, and I would suspect you've got some more hospital-specific data as well as what you submit to VHHA, but this gives you an idea and allows you, by participating in the data collection of VHHA, it allows you to benchmark within your own state, which is a critical piece of information to have, considering that you, and I know this sounds bizarre, but you actually compete with facilities in the state, and so you want to make sure that you are as good or if not better. So benchmarking is a key component for your growth as an individual facility. So if you look at overall sepsis mortality from baseline to remeasurement, there has not been much of a change. And as you can see, not much of a change in severe sepsis and sepsis mortality. Sepsis admissions have stayed pretty much parallel, and sepsis readmission rates. But I will share with you the sepsis readmission rates go along with the national average. So you're benching with the national average in that category. What I will say is you're not benching on the all sepsis mortality and severe sepsis septic shock mortality. Most organizations, their all sepsis mortality is down around 8%, and the severe sepsis mortality is sitting around 6-7%, and shocks around 14-15%, to give an all combined, not including simple sepsis. So if I just were to put severe sepsis and septic shock together, those two together at about 14%. So that'll give you an idea where you stand with the nation and how need to move forward. It's exciting to see the improvement that you've had in the self-reporting measures with regards to compliance to the 3-hour bundle, because you really need to nail the 3-hour before you get to the second half of the process. So from a 62% to roughly about an 80%. So congratulations out there. Woo woo. Well done in that journey. And if you take a look at individual components to give you an idea, you have had significant, and this is just from January to September, some improvement in all of these components to get them close to 90% across the board. And so when you look at your composite measure across the board, you sit around 80%. So the question I asked myself when I was looking at your data, with evidence of that high of a completion in 80%, why is the mortality not changing at all? And so I came up with two thoughts. One is we're not finding them soon enough. So we may have not embedded screening or hardwired our process to identify these patients soon enough. And the second half is how well are we doing on the second half of the bundle? And how much is the septic shock data impacting that combined number? So one of the things that I would ask you to do in your own facility is to make sure that you've separated out severe sepsis and septic shock. It's good to have them combined so that we can see it, because that's how we've been benching it from the beginning. But it's really good for you in your individual facility, and I suspect this data is available because that's how it has to be reported to CMS, to be able to look at all three of those so that you know where your major challenges are as a part of this journey. So really, the key is then to move towards identifying the gaps in the application of the evidence based on where you're at with your data. So you're looking at compliance, 90% compliance. So I would hope that each of your teams have set performance targets for these process measures. 100% is probably unrealistic. I would say 90% compliance would be great. If you haven't initiated screening, I would strongly consider it, because the evidence shows that it does make a difference in mortality. And if you have implemented screening, I would make sure that your screening process is strong, that you've actually evaluated and audited that process to make sure you get 100% screening and triage and nursing shift assessments, and that the screening is being done correctly. Prioritize your work. You're looking, so if screening's your issue, focus heavily on that so you pick these patients up. You're at 80% on the first 3 hours of the bundle. Work to get it to 90 and then move on to the 6-hour component. A big piece of this, and I'm going to dissect it a little more, is this go and see and walk the process, talk to the frontline staff, find out what the barriers are, take a look at your major barriers and potentially use some quality improvement tools like a fishbone diagram to identify where the challenges are, to come up with effective action plans. And that's literally what you need to do, is create action plans. You can use IHI's model for improvement, plan, do, check, act, whatever your organization is used to using, but using those taking the data, taking what you find, and creating the necessary change. So in determining the gaps, it is absolutely critical in understanding the why. We know that success relies on a complex set of tasks being completed in a limited amount of time, and there is no better definition of that than the bundles, because these are the most complex patients. It is a difficult diagnosis. It is difficult to recognize, and we only have a limited amount of time, not because of CMS, but because we know that timing impacts mortality. The data collection and analysis can create bottlenecks, but I think we can overcome that with some of the strategies. We've got to understand our workflow. Since the CDC and their publication that came out in 2016 saying 80% of our patients come in from the emergency room, we absolutely have to understand what that looks like, and we'll talk about some strategies on how to do that. If you're not hooked in to your PI teams, making sure facilitators are there to help with your sepsis team. Multiple tools out there to help in being successful in this journey. So what I'd like to do is talk about what this go and see walk is. And I've used this process as a consultant. Sometimes I've been the patient where I blindly walk into an emergency room. The administrators know this is happening, and I pretend to be septic to see how the process goes. And I know other organizations, some have actually used their mom or somebody that the staff wouldn't recognize to do this. So what is the purpose of a go and see walk? It's really to share experiences and learn from each other right at the site, on site. And the input is used to create a process map. What is our current state of the way we do this to be able to analyze what's working and what isn't? And it's a format to collaborate during and after the redesign, understanding this from a system perspective as a part of it. It helps this visualization, because I know part of my learning is visual, and so that's really important. Create this value stream map for how we identify these patients and how we provide care. And then we can provide constructive criticism, or actually I don't call it criticism, constructive feedback. And we should be taking this feedback from people outside departments, and as well as listening to the people inside. And so what do you need to begin this kind of go see? It would be good to have representative colleagues from the department. You want to give them a copy of the current state map template, and I'm going to show you that. A proposed tour which illustrates the patient flow regarding sepsis care. And then you really want these frontline colleagues to speak out on problems and challenges they're seeing as you do this walkthrough. So let's talk about the emergency room. Start at the beginning of the process where the patients are introduced into the ED. And you'll be interested to note when I started this journey, a lot of the triage happened by a clerk, the registration clerk, or it happened by the security guards. Because there wasn't full-time, 100% of the time, a registered nurse at triage, at the desk, at the front desk. I'm not talking triage, I'm talking at the front desk. And I know this has changed a lot in organizations, but this may be something you discover as you walk your process. So you want to do the patient path of sepsis care and allow people to absorb what they're seeing. Engage the colleagues to tell their view of the story that they're seeing and share that, and share any visuals or specific tools the ED is using to help in their screening process or help remember, and let them see it, hear it, take notes, because you're gonna, it's almost like a simulation. It's a live simulation with debriefing. So you want to fill out, and I'm just going to give you an example of what the map, let me see if I can go back here. Oh, all right, let's see if I can get a picture. There we go. So this will give you for walk-ins. And this is sort of the tool that individuals, so this is sort of the process. If your process is different, you have to add the pieces to it of what you believe is currently happening, and then people make notes on this as they're going through it. So I wanted you to be able to see that. All right, so fill out that current map as they proceed through it. Look at what may be wasteful, jot down an example of it, see what you believe is working. You can do this tour all the way up to the ICU and see how the handoff is occurring as a part of it. Because I got to tell you, watching it versus having somebody tell you what they do is significantly different. Because what I've discovered is a lot of people know exactly the right thing to say, but we may not always do what we say. And I don't know if that makes sense, but I have seen it over and over with the consulting that I do. Have everybody summarize what they are seeing to begin the discussion off, what they've seen, how it relates to problems in treating the septic patient, and how to capture those thoughts on these mapping templates. Feedback is better in the form of questions. It tends to get people delivering, and it's feedback and not criticism. It's an open forum for improvement. Understanding how they think is more important than the solutions they come up with. So what do they think about, how they think about the solutions, than jotting down all the solutions. So as they come up with ideas, have the group talk about what do they think about them. If I was conducting this, or the individuals on the sepsis team, there is likely going to be things that I have not thought about, or I think about it in a different way, and we have to be very open to that because we're not in everybody's shoes as a part of this. So in the exercise, and I would encourage you to perform this exercise strongly. I would encourage you perform the go see and draw a current state map. Identify the customer's requirements, the suppliers, major steps, technology that's needed, information flow, what rework loops happen, what are the delays, and data boxes with job titles so you know what people are doing what. If there is no septic patient presenting when you're doing this, one, you can choose one of the staff or choose one of your family members, as I said, to almost create a simulated treatment process as they go through. So that's another strategy. So there's an example of the flow template for walk-ins. And there's also a flow template for ambulances. And then there is a sepsis patient flow template for the ICU. So it tells you what are supplier inputs, what are customer inputs, and it gives you some direction of what to fill as a part of that. And then the current state issues, these will come out of your process boxes and what the issues are and the reasons why. And this will then allow the team to begin creating some concrete solutions to allow your plan to, check, act, process. And this is where small test to change can come in, where you try new things on a couple of patients and see how it works before you implement throughout the entire emergency room or throughout the entire ICU as a part of it. This is an example, and I know it's really small, but you're going to get it on a PDF so you can expand it. This is an actual cause and effect diagram that was done for the question, why isn't the 30 ml kilogram fluid bolus not given? And the themes, so they looked at all the aspects, communication, materials, the critical thinking process, what are policies, what are the environment, EMR, things like that, and what are the people and knowledge components to it. And the themes they came up with, knowledge and comfort in using the protocol, accepting when physicians don't want to do the protocol without going up the chain of command, fear of fluid in elderly, chronic renal failure and congestive heart failure, which we've talked on, aim hypotension on other conditions, and an unassertive RN staff. So I thought that would be interesting to show you as an example of how you can take one of those process steps that you may be having problems with in your process data that you're seeing, and how to break it down and begin to identify what are the issues so that you can solve them. And so that measuring success and CQI is clearly a part of this journey. And as you can see, we're really looking at this sepsis data measurement and feedback component as a part of this journey. So what I'd like to do before I get into the core measures, and I know we're sort of breaking normal routine here, is what I would like is and if this is okay with Betsy and Joyce, I would like the group to ask some questions with regards to the data piece, the data collection piece, and process improvement before we move on to the coding.
Yeah, we can certainly do that. So
Sure.
everyone from the GoToWebinar platform, you can ask your questions two ways. If you called in over your phone line, you can raise your hand and I'll unmute your line and you can ask your question with Kathleen, or you can type it into the questions portal of the GoToWebinar platform.
And Betsy, you're going to have to tell me because I'm only getting the chat, not the question and answer box.
Mm-hmm.
Don't be shy. This is one of the toughest challenges. Come on, guys. Well, if we don't get any questions, what I'll do is I'll move through the coding and then write down your question as you think of it, and I'll do questions. Do we have a question?
The only question that came in the chat box right now says, can you share the checklist you use?
Actually, it has been shared on previous webinars, but we can send it back out again.
Okay.
We'll do that.
Okay. All right. So in terms of the coding, and I'm not exactly sure how many coding people or individuals, but I think it's important that we know this information so that we're comfortable when we talk with our teams. So data elements, so in terms of the algorithm, the first abstract moved to broad spectrum antibiotics, blood culture collection, and then lactate. In terms of the criteria for SIRS, documentation defining an abnormal value can be discarded based on, and I've always educated on the nurse's screening tool that if they're on chemotherapy, you shouldn't be using the platelets. If they have AFib, you shouldn't be doing tachycardia. You should be using tachycardia and exclude heart rate as a part of it. So that can be done both on the front end and the back end on the coding side. SIRS criteria are organ dysfunction due to acute or acute on a chronic condition. Those values can be used. So basically, if they're having an acute exacerbation of something, of a chronic condition, that still is an acute event. Okay. Oops. All right, fluid. The journey. Crystalloid fluid. it recommends or not to abstract crystalloid fluid more than 6 hours prior to an initial lactate of 4 or physician documentation of septic shock. For initial hypotension, only extract 6 hours prior and 3 hours after the initial hypotension or that lactate of 4. Fluid given prior to arrival in an ambulance that is part of the medical record does not require an order, but must have the type of fluid, the volume, the start time, and the rate, duration, or end time in order to be included. OR fluids do not require order if the type, start time, rate, and end time are present. So basically what that means is good documentation, and that's where we need to start working with our ambulances and nursing homes about how to document that if they start the journey. And since this is a collaborative connecting nursing homes with hospitals and their work, this would be an opportunity. In terms of IV fluid determination for patients with obesity, there has to be physician or mid-level provider documentation identifying the patient has obesity and that the clinician has chosen to use ideal body weight. If there isn't, then you can't use it. Acceptable fluid, isolate has been added as acceptable for abstraction. The bullet point indicating don't use the fluids to give medication such as antibiotic was removed, and you can use it. Used to dilute or deliver the antibiotics can be counted as part of your target volume, and also IO is an acceptable route now. Refusal of fluids has to be documented, indicating the patient or decision maker has refused IV fluid administrations prior to or within 6 hours following presentation of septic shock can be used to select value 4. And the coders know what the value 4 is. Okay, hypotension. This changed, and this is an important. Initial hypotension requires 2 low readings in the time frame, does not need to be consecutive, and don't use it from the OR. Persistent hypotension, following target ordered volume, you know, whether that's the 30 ml per kilogram or adjusted. If more than 1 reading in the 1 hour after, or at least 2 readings in the 3 hour would be classified, don't use the BP in the OR. So don't use hypotension or low systolic blood pressure if there is a physician documentation prior to or within 24 hours after sepsis presentation indicating due to the following. Normal for the patient's condition is due to a chronic condition or is due to a medication. And again, this should be part of education on a screening tool for the nurses. So organ dysfunction, basically clarifying creatinine documentation. If you have end-stage renal disease with hemodialysis or peritoneal, exclude creatinine. Documentation of CKD and baseline creatinine values of 0.5 or above can be excluded. So basically it's dealing with the chronic disease. And again, in a screening tool, this would be educated with staff. And the same with don't use the INR or the PTT if they're on these anticoagulative medications for considering it an organ dysfunction. So those are the updates. So I'd like to open the phones. I know we finished a little early, but I thought we were going to get more questions because data is always a challenge. And so I hope you guys take this opportunity to ask me questions.
Yeah, and Kathleen, thank you. There is one question for you that came in while you were speaking on this last section. So the person asked, with the graphs shared on breaking out sepsis groupings, what definitions are helpful for, quote, sepsis, severe, and shock, for example, by MS-DRGs or APR-DRGs, ICD-10s, others?
Well, my understanding is the severe sepsis and septic shock, basically most individuals are going by what DRGs and ICD-10 codes. And also in the CMS coding, if I'm not mistaken, they also have codes for simple sepsis. So basically simple sepsis is the patient's on an antibiotic and they don't have SIRS criteria and they don't have an organ dysfunction. And so what I can do is get more information on that. But they follow the definitions, but I will, if that question, so was that question written out, Betsy?
Yep. Yeah, I'll save it and send
the
it to
question to me, and I'll send a more formal response out to the whole group when I get greater clarification.
Okay. Good. We've got some other questions coming in. Whew. Hang on. Getting behind now. Yeah. So our next question is for you to describe the logistics of the walk. Who did the observations? Was it real time? And how do you maximize your time?
It is real time. If you can find a sepsis patient, you can set it up as a simulation, as we discussed, using a family member or somebody, or you can just pick one of the staff, and they go through the process that they would normally go through. So one of the things you want to do ahead of time is, well, and so your goal of that process is really to capture the current state of the practice, what is currently being done. And so if you're doing the ER, okay, let me see if I can go backwards.
Do you know which slide it is, Kathleen? I might need to advance to that slide.
It's literally the 4 slides before we started the, why don't you take control back and see if you can go to it. So while she's finding it, literally is, needless to say, a patient, and I would definitely have them, I would start with the walk-in, and start wherever they would walk into. So, and that's triage, okay? So one of the things you want to do is look at who participates in triage, making sure you have the right people observing. So you're going to have people doing it, but you want to make sure you have some triage nurses that work in the area watching this. And if you have docs out there as well, list the process steps, each of the process steps. Include the job title of the individual performing those process steps. And and this one's a little tougher, quantify what you would consider any delay time. Now, the question is, let's say, so let me give an example. This patient, I walk up, I tell them I've got a green cough, I've had a fever, I went to my doctor's office, they put me on antibiotics. They took my temperature, I don't have a fever now. My heart rate's elevated. So let's say I meet 2 SIRS criteria. If the process puts me back because of the crowdedness of triage or the backup, puts me back out in the waiting room, I would start clocking a delay. Because I told you I was on antibiotics. So I got a known or suspected infection. I got 2 search criteria. At a minimum, in triage, labs likely should have been drawn. Does that make sense? Hopefully that does. So that sort of gives you an idea. And then you walk through, okay, if this patient screened positive, so needless to say, you would want this patient to screen positive, so you'd present them with enough that they could, what process occurs? And is it succinct? And then what you can do is you take and write that all out, and you then identify whether people use bundle components, you know, did it seem organized? You're not necessarily going to draw labs, but one of the things you want to find out, that's why it's great to do this on a real patient, is how fast the labs get back. You know, how fast a lactate. And if you don't know that, then it's something you've got to measure. So whatever you aren't able to find out in your walkthrough, then you may need to do measurements. You know, have just in a single day, have them document how long lactates, or evaluate from the time the lactate was drawn to the time it showed up on the computer and the time that the team acted on that lactate. So what this does is allows you to see what's working, what isn't. And I would give, when I've done it, depending on how verbal the group is in discussion and feedback, it can take anywhere from 15 minutes to 45 minutes. But the wealth of information that you're going to get from it is astounding. I mean, and by the way, I also, at some organizations, had administrators there. So ER directors and sometimes higher level administrators, because they almost fell over when the security guard told me. So basically and I'll just share this experience with you, is I went up, there was no nurse at triage. There wasn't anybody there. So I was feeling super sick, quote unquote, and the only other people I saw in the area were the security guard. So I went over and asked them, and they said, oh, I'll go get somebody. So literally the security person was triaging me. So, the initial triage. And the administrators were, oh my God, they had a revelation moment as a part of it. So, and it's good to do this also in the full resuscitation through the ambulance, take it full resuscitation. And also a big time for the ER is the handoff to the ICU and how well that's done.
Mm-hmm. Great. Thanks, Kathleen, for walking us through that. We have 2 more questions in the queue right now. The next is with regard to CF, the medications used to dilute, like an antibiotic, still has to meet the criteria for CF, that's the fluid, right?
Yeah. Yes.
Meaning greater than 125 per hour rate and or duration type, etc. I'm not sure if that's a question or more just a comment.
Yes, but what they're talking about is if you're administering a bolus and it's adding, and it's within that time frame and it's adding to the total volume. That's my understanding of the change. Because before it was excluded. Now, if you're running an antibiotic over 6 hours, that doesn't get included.
Okay.
But a lot of the vancomycin, if people are using vancomycin, not as first line, but if they're using it, a lot of that comes in at 250. And it happens over an hour. So that usually can be included.
Okay. Thanks for that question. The next one is, when it comes to antibiotics, if an aminoglycosis is given prior to the monotherapy antibiotic, but both are within time, which one counts?
So aminoglycoside. Aminoglycosides, my understanding, are not considered full broad spectrum. So you would want what your organization and what fits the criteria for full broad spectrum to be incorporated. At least my understanding is most don't use aminoglycosides as broad spectrum. I would have to get back on that one. Send that question to me, and I'll get clarification. They tend to hit gram negatives more than gram positives.
Yeah.
All right. It looks like that is our last question for now. Let me see if I have any hands raised. Eleanor, it looks like you put your question into the chat, so I think we covered that.
Then I can hand it.
That we have.
Okay, and then I'll hand it to Joyce to close up and talk about next steps.
Thank you, Kathleen. It's been a really informative webinar. I've learned a few things myself in this presentation, so we really appreciate that, and thank you for the questions that we received from the participants. We will follow up with you all afterwards for any further responses to the questions, as Kathleen stated. When you close from the webinar here, you will receive a survey of 6 questions that we have at the end of each of the webinars. And we ask that you quickly fill that out. It won't take you but just a minute or two to be able to do that. And we appreciate your feedback and comments to help us as we move forward with any further educational benefits as part of this project. Once we close, as you know, this was recorded, and the recording we will let you know when it is posted to the HQI resource webpage, as our other webinars have been. Betsy, any other issues or concerns that we need to address?
No, ma'am, that does it.
And happy holidays, everyone.
Absolutely, absolutely. Thank you all, and I'll be following up with an email to you. Happy holidays.